Good morning everyone. Our study is all about chronic obstructive pulmonary disease. So, first of all, what is chronic obstructive pulmonary disease or COPD? Chronic obstructive pulmonary disease or COPD is a common lung disease, and having this kind of disease makes it hard to breathe. There are two main forms of COPD: the chronic bronchitis, which involves a long-term cough with mucus and emphysema, which involves damage to the lungs over time. Most people with COPD have a combination of both conditions. An exacerbation of COPD is a sustained worsening of the patient's condition from the stable state and beyond the normal day-to-day variations that is acute in onset and may warrant additional treatment in a patient with underlying COPD. Persons with chronic bronchitis develop increase in their airway resistance as a result of bronchial wall tissue changes, mucosal edema, and excessive mucus production. Excess mucus in the airways not only obstructs the airflow, but also often causes bronchospasm, which further increases the airway resistance. Persons with COPD often unconsciously reduce their activities of daily living or their ADL to accommodate their respiratory symptoms. They usually not seek medical help and until their symptoms are severely exacerbated, often by a respiratory infection, or until the respiratory symptoms interfere significantly with ADLs, resulting in diminished lifespan. Our patient is FPR, a 78-year-old male which is diagnosed with chronic obstructive pulmonary disease in acute exacerbation. He had a cough with whitish phlegm 1 month prior to admission, had a history of community-acquired pneumonia, moderate risk, and bronchial asthma, and a previous case of hypertensive cardiovascular disease. Persistence of dyspnea, which is unrelated to salbutamol nebulization, prompted him for seeking health care. Therefore, a study of the patient's condition will be presented. This will show how the disease process occurred, the risk factors, its clinical manifestations, possible complications if left untreated, the lifestyle of the client prior to the onset of disease, the pharmacologic and non-pharmacologic interventions, and how this will be managed. For the demographic data, name is FBR. Age is 78 years old. He is from Malunggay-Dawin, Negros Oriental. He is born on April 30, 1943. Mobile number is 0906618769. He is married and a Filipino and a Roman Catholic. Educational attainment is college. Occupation is a house worker. Health insurance is only the Philippine Health. Contact person is his daughter. The date and time of admission is on 3/5/2020 at 12:40 a.m. Physician is Charlotte Y. Shanks.
So next, I'm going to report about the past health history, history of present illness, and the genogram of the patient. For the past health history, patient's name is FBR. Age is 78 years old. Sex is male. Civil status is married. Religion, Roman Catholic. Highest educational attainment, Bachelor of Science in Engineering in University of the Philippines. Occupation, retired power plant engineer. Address, Villa Antonia, Banawa, Cebu City. Date of admission, October 11, 2020. The time of admission, 12:50 p.m. Complaints, dyspnea, 1 month cough with phlegm. Doctor in charge, Dr. David D. For the general data, chief complaint is dyspnea. History of present illness. Mr. FBR is a 78-year-old adult married from Villa Antonia, Banao, Cebu City, who presents with observable signs of dyspnea. On September, 1 month prior to admission, patient had cough with whitish phlegm. The patient also experienced onset of dyspnea and claimed that he is unrelieved with salbutamol nebulization. 3 days prior to admission. The persistent sign of dyspnea prompted the patient to consult for his condition, hence admission. For the past history, previous case of hypertension, cardiovascular disease or HCVD, last admitted on February 2020 due to community-acquired pneumonia, moderate risk, and bronchial asthma. Childhood illnesses include chickenpox, cough, cold, and fever. Serious illness includes asthma and hypertension. For the hospitalization and surgeries, the patient is last admitted on February 2020 due to community-acquired pneumonia. And for the lifestyle and health practices, patient eats 3 times a day, usually vegetables in soup, like tinola in the afternoon, and drinks 10 to 12 glasses of water. The patient sleeps at 10 p.m. and wakes up at 6 to 7 a.m. The patient also has a history of smoking and started since he was 16 years old. And also, he can consume 20 sticks of cigarettes per day and drinks alcohol occasionally. For the developmental level, aged adult, integrity versus despair. Travel history, no recent travel, allergies, allergic to dust and pollens, immunization, complete, heredofamilial diseases, asthma and hypertension. Medications include salbutamol nebulization. Next would be the genogram. Genogram is a graphic representation of a family tree that displays detailed data on relationships among individuals. So this is the genogram of the patient. For the legend of the genogram, the circle shape are male and the triangle shape are female. And if the shapes are indicated black, so they are dead. And if the shapes are indicated or are colored orange, so it means it died with an illness. And H for hypertension and A for asthma. So as you can see in the diagram, it really shows that the patient had a genetic or familial gene of hypertension and asthma. Thank you.
Hi everyone, I am Carla Jean Emily Salisa, and this time let's talk about the genogram, brief anatomy and physiology, and the growth and development. Let's start with the genogram. So for the male, it is represented with circle and shaded white, and the female is represented with a triangle, and the patient is represented by circle shaded with brown. People who died with illness are represented by yellow color. A is for asthma, H is for hypertension, and dead patients are represented by gray shades. So for the growth and development, let's start from the middle old. This age group is more likely to experience limitations on physical activity due to chronic disease such as arthritis, heart conditions, hypertension, especially for women, and hearing or visual impairment. Rate of death due to heart disease, cancer, and cerebral vascular disease are double that experienced by people 65 to 74 years old. Poverty rates are 3% higher, 12% than those between 65 and 74. However, the majority of these 12.9 million Americans live independently or with relatives. Widowed is more common in this group, especially among women in old age. Sense of touch starts to decline. The bones become more brittle as they lose calcium and other minerals. Similarly, joints become less flexible as the joints lose fluid and cartilage begins to rub together. Though the degree of vision impairment varies among individuals, almost everyone over the 55 will need glasses at least part of the time. The most common visual difficulty at this age is focusing on things very close. This decreased ability to detect vibration and pressure may result in injury. In fact, many other people have a reduced sensitivity to pain. Older people are more susceptible to chronic disease such as diabetes, lung disease, arthritis, and hypertension. Ego integrity versus despair is the eighth and final stage of the Erik Erikson stage theory of psychosocial development. This stage begins at approximately age 65 and ends at death. It is during at this time that we contemplate our accomplishment and can develop integrity if we see ourselves as leading a successful life. As we grow older and become senior citizens, we tend to slow down our productivity and explore life as a retired person. Erik Erikson believed if we see our lives as unproductive, feel guilt about our past, or feel that we did not accomplish our life goals, we become dissatisfied with life and develop despair, often leading to depression and hopelessness. Success in this stage will lead to the virtue of wisdom. Wisdom enables a person to look back in their life with a sense of closure and completeness and also accept death without fear. So let's go now to the brief anatomy and physiology involved in our case presentation. So first is the respiratory system. So the respiratory system is the network of organs and tissues that helps us breathe. It includes our airway, lungs, and blood vessels. The mucus that power your lungs are also part of the respiratory system. This spark works together to move oxygen throughout the body and clean out waste gases like carbon dioxide. So first is the trachea. The trachea is located just below the larynx. The trachea is the main airway to the lungs. Next is the bronchi. So the bronchi branch from the trachea into each lung and create the network of intricate passages that supply the lung with air. Next is the alveoli. So alveoli is a tiny sac in the lungs where the exchange of oxygen and carbon dioxide takes place. Next is our bronchioles. The bronchioles are our small branches of the bronchial tubes that leads to the alveoli. And the lungs. Together, the lungs form one of body's large organs. They're responsible for providing oxygen to capillaries and as well as in exhaling carbon dioxide. So that's it for my topic. And now let's go to the next topic.
So, for the next topic, I will be taking up the report for the discussion of the disease condition and the pathophysiology of chronic obstructive pulmonary disease. So, for the discussion of the disease condition, we will define COPD. So, what is COPD? It is a group of progressive lung disease that causes obstructed airflow from the lungs. It's typically caused by long term exposure to irritating gases or particulate matter, commonly cigarette smoke. People with COPD are at risk of developing heart disease, lung cancer, and a variety of other conditions. So, what happens in COPD is that during inhalations, air travels down your windpipe, into your trachea, and into your bronchi, into your bronchioles, and lastly, into the alveoli. The air sacs or the alveoli have very tiny walls full of tiny blood vessels or the capillaries. In there, the oxygen in the air you inhale passes into these blood vessels and enters the bloodstream. At the same time, the carbon dioxide is exhaled. Your lungs rely on the natural elasticity of the bronchial tubes and air sacs to force air out of your body. COPD causes them to lose their elasticity and overexpand, which leaves some air trapped in your lungs when you exhale. This leads to the tissue damage or tissue inflammation and thus increasing mucus secretion in the airway and alveoli. And most common symptoms for these is having a barrel chest. So, what causes the airway obstruction in COPD? So, we have two kinds of COPD, which is the emphysema and the chronic bronchitis. So, first is emphysema. So, this is a lung disease that causes destruction of the fragile walls and elastic fibers of the alveoli. Small airways collapse when you exhale, impairing airflow out of your lungs. There is decreased exchange of gases leading to decreased oxygen in the blood. Eventually, patients have a severe difficulty in breathing. And for chronic bronchitis, your bronchial tubes become inflamed and narrowed, and your lungs produce more mucus, which can further block the narrowed tubes. You develop a chronic cough trying to clear your airway. The trachea can also be involved. Inflammation due to irritants caused inflammation, leading to an increase in the number and the size of mucus secreting glands. There is also damage to the airway cilia, which are small hair like structures that help clear mucus. As a result, these obstruction can decrease the clearance of mucus, which accumulates and thickens, causing area obstruction. Chronic inflammation also leads to narrowing of the airway. And there are many causes of COPD. The first leading cause of COPD is tobacco smoking, which accounts to 90% of COPD risk. Environmental factors such as passive smoking, indoor cooking with poor ventilation, air pollution, exposure to chemicals, exposure to industrial dust and fumes, intravenous drug abuse, infections such as HIV, genetic disorders such as Marfan syndrome, and alpha 1 antitrypsin deficiency. This alpha 1 antitrypsin is a protective barrier in your respiratory tract, wherein if you're deficient in this, you're susceptible to COPD. So there are four stages of COPD. So stage 1 is mild COPD. Symptoms are mild and often missed, but the damage of the lungs begin. Symptoms include persistent cough, which could be dry or accompanied with mucus that is clear, white, yellow, or green. Shortness of breath on exertion. Stage 2 is called moderate COPD. Persistent cough with mucus that may be worse in the morning. Symptoms include shortness of breath, even with mild routine activity, wheezing on exertion, disturbed sleep, and fatigue. Severe COPD is our stage 3. It had bigger impact on the quality of life. The symptoms include worsening consistently. Additionally, it also includes frequent respiratory tract infections, swelling of the ankles, feet, and legs, tightness in the chest, trouble taking a deep breath, and wheezing and other breathing issues when doing basic tasks. And lastly, for the stage 4, we have very severe COPD. This is the final stage of COPD. Occurs after years of continuous damage to the lungs. Patients have worsened symptoms of stage 3 and frequent flare ups that are sometimes fatal. Patients have a very poor quality of life. Symptoms include barrel shaped chest, constant wheezing, being out of breath or dyspnea, delirium, increased heart rate or heartbeat, loss of appetite and weight, and also increased in blood pressure. For the pathophysiology of chronic obstructive pulmonary disease, We have the alpha 1 antitrypsin deficiency as a predisposing factor. For the precipitating factor, we have the smoking or exposure to tobacco smoke, occupational hazard, and pneumonia or childhood respiratory infection. So for the COPD, we have the prolonged exposure to smoke. If you have been exposed to smoke for the longest time, your alveolar macrophages undergo phagocytosis. The mucous, your mucosal glands will also be inflamed and agitated, and also there will be a ciliary destruction. First, let's cover the alveolar macrophages undergoing phagocytosis. So when this happens, there is a release of cytokines which increases neutrophils and macrophages. And it has been seen in the laboratory test that the patient has increased neutrophil count which accumulates to 85.5%. So after the increase of neutrophils and the macrophages, there will be a release of protease enzyme called the elastase. So the elastase breaks down the elastic tissue called the elastin. So if the patient has the alpha 1 antitrypsin deficiency, which protects the lungs from infection, plus the severe elastin release because of the prolonged exposure to smoke, there will be a breakdown of the elastic tissue, or the elastin. When this happens, the recoil ability of the lungs will be reduced, thus increasing lung compliance. Increase in lung compliance will result to air trapping, thus patient manifesting the barrel chest. When the lung compliance is increased, there will be a constant air bombardment and alveolar destruction. And the alveolar destruction is also called the emphysema. And now let's go back to inflammation and agitation of mucosal glands and the ciliary destruction. So when the mucosal glands are inflamed and agitated, the patient will manifest wheezing, and medication for this is hydrocortisone and aspirin, which reduces inflammation. After the inflammation and agitation of the mucosal glands, there will be a hypertrophy and hyperplasia of submucosal glands and epithelial cells. The medication for this is ipatropine, which lower parasympathetic activity of mucosal glands. And for the ciliary destruction, after that is ciliary shortening, less motility, thus increased in mucus production. So for the mucus production, it is seen in the laboratory that the lymphocytes of the patient accumulates to 9.0%. After the increase in mucus production, there will be a narrowing of the airway, and the patient manifests a 1 month cough with phlegm and coarse crackles. The medication made by the doctor is albuterol, which relaxes smooth muscle. So after the airway was narrowed, there will be, of course, an airway obstruction. This airway obstruction will lead to impaired expiration, carbon dioxide trapped inside the alveoli, thus air trapping also occurs. And also another thing is there will be an impaired inspiration, low oxygen getting in, thus impairing gas exchange. So the impaired gas exchange will lead to hypoxemia and hypercapnia, leading to dyspnea or shortness of breath. So for the hypoxemia, the patient manifested cyanosis or pale lips and clubbing of the nails. So for the hypoxemia, there will be an increased RBC production. And it is seen that the patient in the laboratory test that the RBC has increased. After the increase of the production of RBC, the blood becomes viscous, and this viscosity will lead to the blood being hard to pump by the heart. And the medication made by the doctor is digoxin, which increases cardiac contraction. And after that, there is an increased arterial pressure, which leads to pulmonary hypertension. And for the pulmonary hypertension, the medication made was carvedilol, which lowers hypertension. And the pulmonary hypertension increases the risk for person with high cholesterol levels. And the medication made by the doctor was simvastatin, which slows cholesterol production. So, for the pulmonary hypertension, which happens in the pulmonary artery, will be a block flow of blood to the right side of the heart. Backflow will congest the inferior and superior vena cavas. This backflow will continue into the liver, which causes hepatic vein congestion, thus leading to edema. The patient had manifested grade 1 bipedal edema, and the doctor made the medication for the patient, which is furosemide, which increases excretion of salt and water by the kidneys. That's it for the pathophysiology of chronic obstructive pulmonary disease.
Good morning, ma'am. Good morning, everyone. I am Erica Visereño, and I am going to report about nursing and medical management. So, performance of the leadership functions of the governance and decision making within organization employing nurses. So, for the management of patients with COPD, should be incorporated with teaching and improving the respiratory status of the patient. So, first we have to do an assessment. So, for the nursing assessment, we have to assess of the respiratory system, and then we have to assess patients' exposure to risk factors such as allergens like seafoods, um, dust mites, or air pollutants, or even betadine. So, next, we also have to assess the patient's past and present medical history. And also, we have to assess the signs and symptoms of COPD and their severity. We also have to assess the patient's knowledge of the disease so that we have a basis for our health teaching. And we are going to assess also the patient's vital signs and then the breath, sounds, and pattern for us to know if there is an airway obstructions. Next, we have this nursing diagnosis. So some of those includes impaired gas exchange. So impaired gas exchange due to chronic inhalation of toxins. Ineffective airway clearance related to bronchoconstrictions, increased mucus production, ineffective cough, and other complications. We also have ineffective breathing pattern related to shortness of breath, mucus bronchoconstriction, and airway irritants. We also have self-care deficits related to fatigue. Next is activity intolerance related to hypoxemia and ineffective breathing patterns. Next is for our planning and goals. So the nursing care plans, we have these goals to achieve in patients with COPD, and this includes like improvement in gas exchange. We also, it is also our goal to have an achievement of airway clearance, improvement in breathing pattern, independence in self-care activities, improvement in activity intolerance, ventilation or oxygenation adequate to meet self-care needs. We also have nutritional intake, meeting caloric needs, infection treated or prevented. We also have disease process or prognosis and the therapeutic regimen understood. And lastly, plan in place to meet needs after discharge. So we also have these nursing priorities. So first is we have to maintain airway patency. It's very important, especially in the PACU. And next is we have to assist with measures to facilitate gas exchange. Next is we have to enhance nutritional intake, prevent complications or slow progression of condition, and then we also have to provide information about the disease process or prognosis and treatment regimen. So for the nursing intervention, patient and the family teaching or patient and family teaching is an important nursing intervention to enhance self-management in patients with any chronic pulmonary disorder. We also have it is also important to achieve airway clearance And then the nurse must appropriately administer bronchodilators and corticosteroids and become alert for potential side effects. Next is we have these are some of the examples to achieve airway clearance. First is direct or controlled coughing. So the nurse instructs the patient in direct or controlled coughing, which is more effective and reduces fatigue associated with undirected forceful coughing. So to improve breathing pattern, we also have this inspiratory muscle training. So this helps improve the breathing pattern. Next is the diaphragmatic breathing. Diaphragmatic breathing reduces respiratory rate, increases alveolar ventilation, and sometimes helps expel as much air as possible during expiration. Next, we have this pursed lip breathing. So pursed lip breathing helps slow expiration, prevents collapse of small airways, and control the rate and depth of the respiration. To improve activity intolerance, we also have to manage daily activities. So daily activities must be paced throughout the day, and support devices can be also used to decrease energy expenditure. So we also have this exercise training. So exercise training can help strengthen muscles of the upper and lower extremities and improve exercise tolerance and endurance. Next is walking aids. So the use of walking aids may be recommended to improve activity levels and ambulation. To monitor and manage potential complications, we have to monitor cognitive changes. So the nurse should monitor for cognitive changes such as personality and behavior changes and memory impairment. So we also have to monitor pulse oximetry values. So the pulse oximetry values are used to assess the patient's need for oxygen and administer supplemental oxygen as prescribed. So we also have to prevent infection. The nurse should encourage the patient to be immunized against influenza and as pneumonia because the patient is prone to respiratory infection. So for the medical management, the healthcare providers perform medical management by considering the assessment data first and matching the appropriate intervention to the existing manifestation. So we have some pharmacologic therapy. First is the bronchodilators. So the bronchodilators relieve bronchospasms by altering the smooth muscle tone and reduce airway obstruction by allowing increased oxygen distribution throughout the lungs and improving the alveolar ventilation. Next is corticosteroids. A short trial course of oral corticosteroids may be prescribed for patients to determine whether pulmonary function improves and symptoms to decrease. So other medications that may be used in COPD include alpha-1 antitrypsin augmentation therapy, antibiotic agents, mucolytic agents, antitussive agents, vasodilators, and narcotics. So for the management of exacerbations, optimization of bronchodilator medications is the first-line therapy and involves identifying the best medications or combinations of medications taken on a regular schedule for a specific patient. So, hospitalization. So, indications for hospitalization for acute exacerbation of COPD includes severe dyspnea that does not respond to initial therapy, confusion or lethargy, respiratory muscle fatigue, paradoxical chest wall movement, and peripheral edema. Next is the oxygen therapy. Upon arrival of the patient in the emergency room, supplemental oxygen therapy is administered and rapid assessment is performed to determine if the exacerbation is life-threatening. Next is antibiotics. Antibiotics have been shown to be of some benefit to patients with increased dyspnea, increased sputum production, and increased sputum purulence. Next is for the laboratory and diagnostic results. These help doctors diagnose medical conditions, plan or evaluate treatments, and even monitor diseases. So we have here the blood chemistry. So for the creatinine, the result is 1.3, and the normal value is between 0.4 to 1.4 milligrams per deciliter. So this indicates for to assess the creatinine levels if this show signs of kidney diseases. So next is the sodium. The result is 138 and it is shown to be within the normal value, and this also indicates or it is indicated to measure the amount of sodium in our body or in the blood. Next is the potassium. It is also within the normal value, and then it is also indicated to monitor or diagnose conditions related to abnormal potassium levels. So for the hematology, we have here CBC. So for the RBC count, it is 6.4 and it is indicated to help diagnose the cause of anemia. So it is shown here that um, it is above normal, and the hemoglobin is 14.2, and it is indicated to measure the amount of hemoglobin in the RBC. Next is the hematocrit 48.8, WBC count 6.7, and we also have the neutrophils, which is it is elevated, and it is indicated to measure the
Yes, Sir John.
neutrophil blood vessels increase. The indication for this is for the
Ah,
neutrophil blood vessels
napay sir
increase
kasunod ani
naturally
Sir John.
in response to infections, injuries, and other types of stress. So for the lymphocytes, it is 9.0 and the normal value is 20 to 40%. So
Sige,
it is
sunod
for
kang
severe
Jason.
or chronic
Sige
low
sir,
counts
salamat
can
sir.
indicate a possible infection
While
or
waiting
other
review ra,
significant
ating
illness.
kuhan katong
So
sleeping.
next is the MID
Ay kalimot missing
5.5,
kay importante
and
wala tayo missing.
it indicates the combined value of the other types of white blood cells not classified as lymphocytes or granulocytes. So next is the platelet count 198, and this determines the number of platelets in your sample of blood. So the urinalysis. So the color is straw, appearance is clear, specific gravity is 1.005, pH is 6, protein negative, glucose negative, keto negative, blood negative, nitrite negative, leukocytes negative, bilirubin negative, microscopic examination, pus cells 0 to 1, HPF, red cells none, epithelial cells rare, bacteria are rare, and mucous threads none. So that would be all. Thank you.
Hello everyone, I am Gian Elaine S. Guevara, and now let's proceed to the medications. So, what is medications? Medication is a drug used to diagnose, cure, treat, or prevent diseases. So, first is salbutamol, generic name albuterol, dosage 1 nebulizer, and then 1 nebulizer every 15 minutes times 2 doses every 1 nebulizer every 8 hours. So the route is oral inhalation. Mechanism of action. This increase of cyclic AMP leads to the activation of protein kinase A, which inhibits the phosphorylation of myosin and lowers intracellular ionic calcium concentrations, resulting in relaxation. Salbutamol relaxes the smooth muscles of all airways, from the trachea to terminal bronchioles. Indications. Salbutamol is indicated for the symptomatic relief and prevention of bronchospasm due to bronchial asthma, chronic bronchitis, reversible obstructive airway disease, and other chronic bronchopulmonary disorders in which bronchospasms is a complicating factor, and or the acute prophylaxis against exercise-induced bronchospasm and other stimuli known to induce bronchospasm. Contraindications. Salbutamol is contraindicated in patients with high blood pressure during pregnancy, uterine infection, miscarriage, heart disease, hypersensitivity to the drug, and wide-angle glaucoma. Side effects: dry mouth, dizziness, headache, loss of appetite, nausea, anxiety, bad taste in mouth. Nursing responsibilities: monitor vital signs, monitor input and output, Maintain on high back rest. Do not exceed recommended dosage. Teach patient that he or she may experience the side effects, and teach patient proper use of inhaler. Next medication is Atrovent. Generic name is epratropium. Dosage is 1 nebulizer every 8 hours. Route is oral inhalation. Mechanism of action. Ipratropium is an acetylcholine antagonist via blockade of muscarinic cholinergic receptors. Blocking cholinergic receptors decreases the production of cyclic guanosine monophosphate. This decrease in the lung airways will lead to decreased contraction of the smooth muscles. The action of intranasal ipratropium mimic the action of atropine by inhibiting salivary and mucous glands secretions as well as dilating bronchial smooth muscles. Indications: Ipratropium is indicated for the treatment of reversible bronchospasm associated with chronic obstructive pulmonary disease. Epitropium is indicated when used concomitantly with inhaled beta-2 agonists for treatment of reversible area obstruction as in acute and chronic asthma. Contraindications: this medication is contraindicated to hypersensitivity to the drug, bladder obstruction, prostatic hypertrophy, urinary retention, and wide-angle glaucoma. Side effects: headache, dry mouth, back pain, cough, dizziness, nausea, and bad taste in mouth. Nursing responsibilities: monitor vital signs, monitor input and output, maintain on high back rest, do not exceed recommended dosage, teach patient that he or she may experience the side effects, ensure adequate hydration, control environmental temperature to prevent hyperpyrexia, have patient void before taking medication to avoid urinary retention, and teach patient proper use of inhaler. Or the next medication is the hydrocorp. So generic name is hydrocortisone. Dosage now is 250 milligrams and then 100 milligrams every 6 hours. Route is the IVTT. Mechanism of action: hydrocortisone binds to the glucocorticoid receptor, leading to downstream effects such as inhibition of phospholipase A2 and F-kappa B, other inflammatory transcription factors, and the promotion of anti-inflammatory genes. Hydrocortisone injection works by reducing inflammation, irritating, and swelling in the body. Indications: it is used to treat conditions such as arthritis, blood, hormone, immune system disorders, skin and eye conditions, breathing problems, cancer, severe allergies, and it decreases your immune system's response to various diseases to reduce symptoms such as pain, swelling, and allergic type reactions. Contraindications: hypersensitivity to the drug, measles, high blood pressure, exposure to the chickenpox, a condition of weak bones, and wide-angle glaucoma. Side effects is nausea, headache, dizziness, heartburn, trouble sleeping, and increased sweating. Nursing responsibilities: you have to monitor the vital signs, monitor input and output, maintain on high back rest, do not exceed recommended dosage, teach patient that he or she may experience the side effects, and administer drug as prescribed. The next brand, the next drug is the Lasix. Generic name is furosemide. Dosage is 40 milligrams once a day, and route is IVTT. Mechanism of action: furosemide is a potent loop diuretic that works to increase the excretion of sodium and water by the kidneys by inhibiting their reabsorption from the proximal and distal tubules, as well as the loop of Henle. It works directly, acts on the cells of nephron, and indirectly modifies the content of the renal filtrate. Indications: Paracetamol is used alone or in combination with other medications to treat high blood pressure. Paracetamol is used to treat edema, fluid retention, excessive fluid held in body tissues caused by various medical problems, including heart, kidney, and liver disease. Contraindications: hypersensitivity to the drug, low blood pressure, difficulty in urinating, anuria, renal impairment or renal failure. The side effects are frequent urination, headache, diarrhea, blurred vision, constipation, dizziness, and weakness. Nursing responsibilities: monitor vital signs, monitor input and output, maintain on high back rest, do not recommend do not exceed recommended dosage, teach patient that he or she may experience the side effects, administer drug as prescribed, and administer drug every morning with BP precaution. The next drug is the Coreg. Generic name is carvedilol. Dosage is 6.25 milligrams uh, by tub, so one tub twice a day, and then route is oral. Mechanism of action: carvedilol inhibits exercise-induced tachycardia through its inhibition of beta-adrenoceptors. Carvedilol's action on alpha-1 adrenergic receptors relaxes smooth muscles in vasculature, leading to reduced peripheral vascular resistance and an overall reduction in blood pressure. Indications: carvedilol is a non-selective adrenergic blocker indicated for the chronic therapy of heart failure with reduced ejection fraction, hypertension, hypertension, and left ventricular dysfunction following myocardial infarction in clinically stable patients. Contraindications: absolute contraindications for the use of carvedilol include severe hypotension, second or third degree AV block, sick sinus syndrome, and severe bradycardia in the absence of a functional pacemaker, severe decompensated heart failure requiring inotropic support, and a history of a serious hypersensitivity reaction. Side effects: dizziness, fatigue, weight gain, nausea, diarrhea, slow heart rate, low blood pressure, headache, and vomiting. Nursing responsibilities: monitor the vital signs, especially the blood pressure, maintain a high back rest, do not exceed recommended dosage, teach patient that he or she may experience the side effects, administer drug as prescribed, tell patient tell patient to take drug with meals, avoid use of over-the-counter medications. And the next drug is the Zorprene. Generic name is aspirin. Dosage is 80 milligrams per tab, so one tab once a day. Route is oral. Mechanism of action: aspirin is known as a salicylate and non-steroidal anti-inflammatory drug. It works by blocking a certain natural substance in your body to reduce pain and swelling. Indications: aspirin is used to reduce fever and relieve mild to moderate pain from conditions such as muscle aches, toothaches, common colds, and headaches. It may also be used to reduce pain and swelling and in conditions such as arthritis. Contraindications: hypersensitivity to the drug, gout, bleeding of the stomach or intestines, decrease in blood clotting, and stomach ulcer. Side effects: confusion, stomach pain, nausea, vomiting, ringing in your ears, and decreased kidney function. Nursing responsibilities: monitor vital signs, monitor input and output, maintain on high back rest, do not exceed recommended dosage, teach patient that he or she may experience the side effects, administer drug as prescribed, and administer drug every morning after breakfast. Next drug is the atorvastatin. Generic name is simvastatin. Dosage is 40 milligrams per tab, one tab once a day. Route is oral. Mechanism of action: simvastatin is in a class of medications called HMG CoA reductase inhibitors. It works by slowing the production of cholesterol in the body to decrease the amount of cholesterol that may build up on the walls of the arteries and block blood flow to the heart, brain, and other parts of the body. Indications Simvastatin indications Simvastatin has proven to be highly effective lipid-lowering drug and it is therefore indicated for all forms of severe primary hypercholesterolemia. The indications of lipid-lowering drugs occur mainly in individuals with high cholesterol levels and other coronary risk factors. Contraindications Patients contraindicated to simvastatin pharmacotherapy include those who have active liver disease, elevated hepatic enzymes, pregnancy, women who may become pregnant or are breastfeeding, and hypersensitivity to the drug. Side effects headache, difficulty sleeping, flashing of the skin, drowsiness, dizziness, nausea, vomiting, and abdominal cramping or pain. Nursing responsibilities monitor vital signs, monitor input and output, maintain on high back rest, do not exceed recommended dosage, teach patient that he or she may experience the side effects, administer drug as prescribed, and administer drug during bedtime. Next drug is the Lonoxin. Generic name is digoxin. Dosage is 0.25 milligrams per tab, so one tab once a day. Route is oral. Mechanism of action, digoxin induces an increase in intracellular sodium that will drive an influx of calcium in the heart and cause an increase in contractility. Cardiac output increases with a subsequent decrease in ventricular filling pressures. Indications Digoxin is used to treat heart failure, usually along with other medications. It is also used to treat certain types of irregular heartbeat, such as chronic atrial fibrillation. Treating heart failure may help maintain your ability to walk and exercise and may improve the strength of your heart. Contraindications Digitalis glycosides are contraindicated in patients with ventricular fibrillation or in patients with a known hypersensitivity to digoxin. A hypersensitivity reaction to other digitalis preparations usually constitutes a contraindication to digoxin. Side effects nausea, vomiting, loss of appetite, headache, dizziness, and diarrhea. Nursing responsibilities monitor vital signs, monitor input and output, maintain on high back rest, do not exceed recommended dosage, teach patient that he or she may experience the side effects, administer drug as prescribed. So that's all for the medications and the drug study. Thank you, everyone.
Once again, good afternoon. This is your student nurse Kabanag. And now let us discuss on the physical assessment and functional health pattern. So let's start with the physical assessment. So for the general survey, for the findings, patient FBR, a 78 years old male, married, Roman Catholic, and the educational attainment is BSE, University of the Philippines, a retired power plant engineer, and lives in Villa Antonia, Banawa, Cebu City. Patient is awake, coherent, in respiratory distress, breath through pursed lips, manifests shortness of breath and uses accessory muscles. Observed to be fatigued, lethargic, cyanotic, and thin or less than normal BMI, kyphotic in appearance, needs to be assisted in every activity done. Vital signs For the temperature, it is 37.4 degrees Celsius. For the heart rate, it is 90 beats per minute, which is within the normal range. Respiratory rate is 30 cycles per minute, irregular, with the use of accessory muscles. And as you can see, it is much higher than the normal respiratory rate. And for the BP, we have 150 over 100 mmHg, or as you can also see, it is more higher than the normal range for our blood pressure. For the oxygen saturation, we have 89%, which is less than the normal oxygen saturation. Let's have the integumentary system. As for the skin, during the inspection, skin is dry, free from any lesions, growth. Also, it increases and bluish in color. For the palpation, it is cold to touch and has a poor skin turgor. For the nails, clubbing is observed and is bluish in color. It is rough to touch and has a poor capillary refill, which means that after pressing it and releasing it, after 3 seconds, the nail remains bluish in color. Let's have the hint. As for the findings, patient manifested lightheadedness, blurred vision, cataracts are also noted. Face is equal, no signs of drooping, no involuntary movement such as twitching, no warts, wrinkles, and no inflammation noted. As for the eyebrows, it is equally distributed and is thin. Few scaliness are observed. Ears has the same color with the face, equal in size, is aligned with the body, and is symmetric with an angle attachment less than 10 degrees and no deformities noted. Auditory canal is pale white in color, dry, and has ample of earwax. Nose is equal and has a good shape, symmetrical, no signs of deformities, flaring is noted. Nasal mucosa is pale, white in color, dry, and has ample hair, and the inferior and middle tubernates is dry. Lips is bluish in color, no lesions is noted. No foul odor is also noted. Neck is the same color as the body, no scars and growth noted. Trachea is in the midline, no deviations are noted also. Thyroid gland is intact and the jugular vein is distended. As for the palpation, there is no signs of masses, nodules, and temporomandibular joint is intact. No clenching sound or sensation noted. Ears are rough, dry, and smooth to touch. No nodules and tenderness are also noted. No masses are noted in the head, eyebrows, ears, and nose. Limbs are unpalpable. The sternocleidomastoid muscles are intact. No enlargement or tenderness of thyroid gland noted. Let's have the chest. So the chest for the inspection, it has 30 cycles per minute, irregular with the use of accessory muscles, and there is an increased anterior-posterior appearance. So as we can see that our patient's chest has a barrel-shaped appearance. As for the palpation, tenderness is noted. Respiratory excursion is the lungs expands unequally. As for the auscultation, there is coarse crackles and occasional wheezes heard during auscultation. For the heart sounds, it is normal, no murmurs heard. For the abdomen, we can observe the patient has a bloated abdomen and tenderness is also noted. For the extremities, we have grade 1 bipedal edema. Weakness and restless is noted. And our patient can do the full range of motion. So let's have the functional health pattern. So the functional health pattern is developed by Gordon, which is a method devised by Marjorie Gordon to be used by nurses in the nursing process to provide a more comprehensive nursing assessment of the patient. So let us have the first one, the health perception. As for the usual, patient verbalized that she doesn't feel any sickness. As quoted, healthy raman ko kaayo ma'am, wala ko'y gipang bati-bati na sakit. Patient has history of smoking and started since he was 16 years old and can consume 15 sticks of cigarettes per day and stopped smoking completely at the age of 52 years old. He also drinks alcohol occasionally, is allergic to dust and pollens, and has a complete immunizations. As for the heredofamilial diseases, he has asthma and hypertension. As for the initial, the admitting notes, the chief complaint is patient is having a dyspnea, history of present illness. It is 1 month prior to admission. Patient had cough with whitish phlegm, and also 3 days prior to admission is the onset of dyspnea, unrelieved with salbutamol nebulization. So persistence of dyspnea prompted consultation, hence admission. For the past health history, patient has a previous case of HCVD. For the last admission, it was last February 2020 due to community-acquired pneumonia, moderate risk, and bronchial asthma. For the doctor's order, on October 11, 2020, around 12:50 p.m., for the vital signs, you have 37 degrees Celsius, heart rate 65 beats per minute, pulse rate is 29 cycles, respiratory rate is 29 cycles per minute, irregular with the use of accessory muscles. Blood pressure is 110/70 mmHg and has a 95% oxygen saturation. So, per doctor's order, kindly admit patient, secure consent to care and management. For the problem, patient is having dyspnea. For the diet, have a full low salt hypoallergenic diet. Kindly insert HEPLAC. As for the labs, the doctor order for CBC, urinalysis, chest x-ray, PA, serum sodium potassium creatinine. For the medications, we have the salbutamol plus ipratropium. We have salbutamol plus ipratropium 1 neb now. Then salbutamol 1 neb every 15 minutes to 2 doses. We have the hydrocortisone 250 mg IVTT now, then 100 mg every 6 hours. Furosemide 40 mg IVTT now, then OG-BP PM with BP precautions. And salbutamol 1 neb every 8 hours. Salbutamol plus ipratropium 1 neb every 8 hours. Carvedilol 6.25 mg per tab, 1 tab BIT. Aspirin 80 mg per tab, 1 tab OG-PC breakfast. Simvastatin 40 mg 1 tab, 1 per tab, 1 tab, once a day every HS. Digoxin 0.25 milligram per tab once a day. O2 via nasal cannula at 1.5 LPM. Target oxygen saturation is 90 to 92%. Then monitor vital signs every shift. Monitor input and output every shift. Maintain on high back rest. For chest physiotherapy every after nebulization, please refer accordingly. So as for the ongoing, we have doctor's order. Kindly discharge patient. Secure discharge slip. Continue full low salt hypoallergenic diet. Remove heplock. Follow-up check-up after 1 month. Secure the following laboratories: CBC, urinalysis, chest x-ray, PA, serum, sodium, potassium, creatinine. Discontinue hydrocortisone 250 mg IVTT 100 mg every 6 hours and furosemide 40 mg IVTT OD every AM with BP precaution. Continue salbutamol plus ipratropium 1 neb once a day. Also continue the following medications within 1 week: carvedilol 6.25 mg per tab 1 tab BID, aspirin 80 mg per tab 1 tab OD PC breakfast, simvastatin 40 mg per tab 1 tab OD every HS, and digoxin 0.25 mg per tab 1 tab OD. Discontinue the following procedures: O2 via nasal cannula. Monitor vital signs every shift. And discontinue also the monitoring of the input and output every shift. Maintain semi-Fowler's position when going to sleep. And also continue chest physiotherapy every after nebulization. Let's go to the nutritional metabolic pattern. For the usual, for the breakfast, patient eats 1 bowl of tinola, 3 cups of rice, 1 cup tea, 1 cup water. For the lunch, 2 cups fried rice, 1 bowl soup, 1 piece fish, and 2 cups of water. For the dinner, 2 cups of rice, 2 meat, 1 bowl soup, 3 cups of water. And patient also verbalized that he doesn't have any diet restriction and likes to eat food. Doesn't take any supplements or vitamins, and no known allergies to any food, fluid, or substances. For the initial diet is full low salt hypoallergenic diet per doctor's order. For the food intake, 1/2 cup chop suey, 1 piece banana, 1/2 cup of brown rice, 1/2 cup of cereals, 1 piece salmon fish. For the fluid intake, 2 to 3 glass of water, 1 cup of 100% fruit veggie juice. For the appetite, patient has a poor appetite and there is a change in the patient's weight for the last 1 month. For the ongoing, continue full low salt and hypoallergenic diet. Continue intake of 2 to 3 glasses of water and 1 cup of 100% fruit veg. Let's have the activity exercise. For the usual, patient verbalize feeling of weakness. Verbalize sudden shortness of breath. When exerting a little energy on doing things such as lifting objects, walking a short distance, and doing ADLs. Doesn't use any mechanical aids. Perceive ability ratings. For the ability ratings: feeding 1, shopping 1, toileting 1, dressing 1, cooking 1, general mobility 1, bathing 1, bed mobility 1. So for the initial, patient is observed to be fatigued and weak, cannot do daily activity due to muscle weakness and shortness of breath, uses wheelchair upon arrival and needs someone to assist him every time he moves. Perceive ability ratings is feeding 2, shopping 4, toileting 2, dressing 2, cooking 4, general mobility 3, bathing 3, bed mobility 3. For the ongoing, patient verbalized tolerance in exerting a little energy and doing things such as lifting objects, working a short distance, and doing ADLs. Patient also doesn't use any mechanical aids. For the perceived ability ratings, in all categories it is 0. Let's have the sleep rest pattern. For the usual, patient verbalizes sleeps for a short period of time, wakes up every night and can totally sleep well due to coughing. Doesn't have a quality sleep. Usual sleep pattern is around 8 p.m. For the initial, patient takes a nap every noon and afternoon but verbalize some disturbances due to hospital noises, persistent cough, shortness of breath, and uncomfortable pain and chest tightness. Doesn't have quality of sleep every time he sleeps. For the ongoing, patient sleeps every time he was sleepy or drowsy, no disturbances in the surrounding. Sometimes patient feels shortness of breath in a short period of time. During sleeping, patient verbalized maintenance of semi-Fowler's position. Let us now have the cognitive perceptual pattern. For the usual, patient's language spoken is English and Cebuano. Lives with his wife and children. No sensory perception deficits. Highest educational attainment is education, BSE, University of the Philippines. For the initial, patient is awake, coherent and in respiratory distress, verbalized pain and tightness of the chest, facial grimacing, abdominal gorging, and profuse sweating noted. Rates pain as 9 on a scale of 0 to 10, having 0 as the lowest and 10 as the highest. Verbalized uncomfortable and difficulty in breathing. 3 days prior to admission, onset of dyspnea, unrelieved with salbutamol nebulization, and persistence of dyspnea prompted the patient to consult and hence admission. For the ongoing, patient is awake and free from any respiratory distress. Verbalize that he is comfortable and happy due to relieve shortness of breath and discomforts. Doesn't feel any pain and tightness of chest. Verbalize that medication helps a lot in relieving his discomforts. For the self-perception or self-concept pattern, for the usual, patient verbalize that he is good person, responsible, and have a good heart. Verbalize that he is in a good health, that he could do everything with all his might. For the initial, patient verbalized that he is sad and disappointed in himself due to the illness. Verbalize that having shortness of breath and pain he is feeling makes him so uncomfortable and in pain. For the ongoing, patient improves emotional status and improves health status. For the roles relationship pattern, for the usual, turns to his wife when in need of help. Decision making is always done by both husband and wife. No difficulties or problems within the family members. No losses or big changes in the past year. Has a lot of close friends. Has a close family relationship. For the initial, family role dysfunction is noted. His wife is always by his side to assist him in all activity. Has a close family relationship. And for the ongoing, improved family role dysfunction, his wife is always by his side to assist him in all activities. Has a close family relationship. For the sexuality functioning, patient is circumcised at the age of 14 years old, got pubic hair in the body when he was 12 years old, uses condoms during sexual intercourse, contented with his sex life, have one sexual partner as verb. Patient is uncontented with his sex life due to the illness he has and can't do things since he feels so tired, most especially when he got to exert energy. For the ongoing, patient is contented with his sex life. So let's have the coping stress management pattern. For the usual, patient meditates when he is under stress or simply watches TV or reads some books to occupy him. For the initial, anxiety are observed. Verbalize that his illness makes his self-confidence go down and sometimes he got hopeless due to the quality of life he is experiencing. And for the ongoing, patient is free from any anxiety or distress. Also, he gained confidence and quality of life improves. For the last category, let's have the values belief system. For the usual, he goes to church every Sunday, finds God a source of stress, religion, and God are important to him. He is also a Roman Catholic. For the initial, got his beliefs go stronger, verbalize that he should believe in God's plan for him. And lastly, for the ongoing, patient verbalized faith to God and quoted that tanang naagyan nako kay pagbuot ra sa Ginoo ug musalig ko niya kay tanang butang nairason nganong nahitabo. And he goes to church when tolerated. So that would be all about my topic, the physical assessment and the functional health pattern. And let us have the next reporter. Thank you.
Hi everyone, this is Eunice Abigail Banagrudos and I will be discussing about our three nursing care plans that we come up, our conclusion and recommendation, and of course our two review related literature. For our first nursing care plan, subjective data, patient have not undergone regular checkup despite of the cough experience, verbalizes mura kog malumos. Objective data vital signs as of October 11, the year 2020, 12:50 p.m. Temperature is 37 degrees Celsius, heart rate is 65 beats per minute, respiratory rate 29 cycles per minute, blood pressure 110 over 70 mmHg, oxygen saturation is 95%, increased respiratory rate as evidenced by 29 cycles per minute, uses accessory muscles to breathe, presence nasal flaring, has a history of bronchial asthma, presence of crackles noted on both lung fields upon auscultation, presented with barrel chest and clubbing of nasal in extremities, and swelling or edema. For our nursing diagnosis, effective breathing pattern related to retained secretion of white phlegm. Our desired outcomes, we have short term and long term goal. Short term goal at the end of our 8-hour nursing intervention, the client will establish improvement of deep breathing pattern as evidenced by breathing without use of accessory muscles and absence of dyspnea. For our long term goal, at the end of 5 days nursing intervention, the client will establish a normal effective respiratory pattern as evidenced by a respiratory rate within normal range of 12 to 16 cycles per minute and absence of signs or symptoms of low oxygen, barrel chest, or clubbing nails. For our nursing interventions and its rationale, independent intervention, we have here auscultate breath sounds every 2 to 4 hours. Any abnormal breath sounds that can be observed must be reported immediately for treatment. Place client in a position with a proper body alignment. Sitting position permits maximum lung and chest expansion to maximize breathing pattern and encourage slower or deeper respiration. Use of pursed lip technique assist client in taking control of the situation. For our dependent intervention, administer a combination of inhaled corticosteroids and bronchodilators medication. It is more effective than any single treatment in decreasing episodes of exacerbations and provides overall improvement of lung function. Administer oxygen at lowest concentration indicated for management of underlying pulmonary condition and respiratory distress. Suction airway as needed to clear secretion, and medicate with analgesics as appropriate to promote deeper respiration and cough. For our evaluation, at the end of 8-hour nursing intervention, the client was able to breathe without the use of accessory muscles and exhibits relaxed breathing pattern. After the 5 days nursing intervention, the client was able to demonstrate normal respiratory rate of 14 cycles per minute within normal range and diminished signs of low oxygen. For our nursing care plan 2, subjective data, patient verbalizes maglisod gud ko ginhawa. Objective data, the same thing for the vital signs taken, temperature 37 degrees Celsius, heart rate 65 beats per minute, respiratory rate 29 cycles per minute, blood pressure 110 over 70 mmHg, and oxygen saturation 95%. Difficulty in breathing as evidenced by use of accessory muscles, increased respiratory rate of 29 cycles per minute, crackles and occasional wheezing noted upon auscultation, and swelling or edema. For the diagnosis of those assessment, it is ineffective airway clearance related to COPD as evidenced by shortness of breath or dyspnea, crackles, and productive cough with whitish phlegm. For our desired outcomes, short term goal at the end of 2 hour nursing care, the patient will be able to improve airway patency as evidenced by being able to expectorate phlegm effectively, lung sounds will be clear to auscultate, and will verbalize ease of breathing. For our long term goal, at the end of 24 hours nursing intervention, the patient will be able to establish normal respiratory rate within 12 to 16 cycles per minute and will maintain a patent airway. For our nursing interventions and its rationale, for the independent intervention, assess patient's vital signs including the characteristics of respiration every 4 hours to create an accurate diagnosis and monitor the effectiveness of medications administered, elevate the head of bed and or assist in semi-Fowler's position. It is to help improve expansion of lung and enables breathing effectively, and assist the patient to turn every 2 hours to aids in mobilizing secretions to facilitate clearing of airways. For the dependent interventions and its rationale, administer prescribed medications, bronchodilators, steroids, inhalers, or nebulizers. For bronchodilators, dilate or relax muscle on airways, and for steroids, it reduces inflammation in lungs. Suction secretions, it is to help clear the thick phlegm and assist patient in increasing fluid intake to 3,000 ml per day within cardiac tolerance, provide warm or tepid liquids. Hydration helps decrease the viscosity of secretions, facilitating expectoration. Using warm liquids may decrease bronchospasms. For the evaluation at the end of 2 hour nursing care, the patient was able to expectorate phlegm effectively, lung sounds clear upon auscultation, and claimed to have easier breathing pattern. And for the long-term goal, at the end of 24 hours nursing intervention, the patient has established a normal respiratory rate of 16 cycles per minute and maintains a patent airway. For our nursing care plan, 3 hour subjective data, patient verbalizes, dili nako makabuhat sa akong mga trabahoon, kay dali nako hangukon og kapuyon. Slow movement noted. For our objective data, increased capillary refill 4 to 5 seconds, cold and clammy skin, excessively increased respiratory rate 29 cycles per minute, and the same thing as the vital signs. Temperature is 37 degrees Celsius, heart rate is 65 beats per minute, respiratory rate is 29 cycles per minute, blood pressure is 110 over 70 mmHg, and oxygen saturation of 95%. For our nursing diagnosis, activity intolerance related to compromised oxygen transform, and for our desired outcomes, short term goal after the 8 hour nursing intervention, the patient will demonstrate increase in activity level as evidenced by tolerance of activities and active range of motion. And for our long term goal, after 24 hours of nursing intervention, the patient will report reduced dyspnea during an activity and achieve desired level of activity as evidenced by diminished intolerance upon activity exertion. For our nursing interventions and its rationale, independent, give assistance to patient when moving, occurrence of injury may be prevented, and to make patient do not feel exhausted, reposition patient every 2 hours. It is to avoid occurrence of conditions such as bed sores and pneumonia. assess muscle strength to serve as basis for planning progress, and teach the patient on exercises that enhances breathing capacity such as diaphragmatic and pursed lip breathing, helps prolong exhalation period and reduce retention of carbon dioxide. For our dependent intervention and its rationale, maintain prescribed activity levels. It helps in building tolerance and minimizing episodes of dyspnea. Teach and assist the patient with active range of motion exercises. Aids in building stamina and avoid complications of limited mobility, and instruct patient with energy conservation techniques like sitting task, frequent position changes. It is to reduce oxygen consumption, allowing a more prolonged activity. And for its evaluation, after the 8-hour nursing intervention, the patient demonstrated increase in activity level as evidenced by tolerance of activities and able to perform active range of motion exercise. And after the 24 hours nursing intervention, the patient reported no dyspnea during an activity and achieved desired level of activity with no intolerance noted. Summarize it all, patient FBR, 78 years old male, presented to the hospital with chief complaint of dyspnea. Nursing diagnosis are as follows. First priority nursing diagnosis is an effective breathing pattern related to retained secretions of white phlegm. These are evidence respiratory rate of 29 cycles per minute, which is above normal range, use of accessory muscles, and exhibits nasal flaring. Its nursing interventions and rationale are presented on the table. And at the end of 5 days nursing intervention, the client was able to demonstrate normal respiratory rate of 14 cycles per minute within normal ranges, able to breathe without the use of accessory muscles, and exhibits relaxed breathing technique or breathing pattern. Second priority nursing diagnosis is ineffective airway clearance related to COPD as evidenced by shortness of breath or dyspnea, crackles, and productive cough with whitish phlegm. Its nursing interventions and rationale are presented in the table. At the end of 24 hours nursing intervention, the patient has established a normal respiratory rate of 16 cycles per minute. The patient was able to expectorate phlegm effectively, lung sounds clear upon auscultation, and maintains a patent airway. For our third priority nursing diagnosis is activity intolerance related to compromised oxygen transport, evidenced by body weakness, fatigue, inability to perform activities of daily living, cold and clammy skin, and increased capillary refill time. Nursing interventions and rationale are presented in the table. After the 24 hours nursing intervention, the patient reported no dyspnea during an activity, achieve desired level of activity with no intolerance noted, and able to perform active range of motion exercise. For our conclusion and recommendations, chronic obstructive pulmonary disease or COPD kills more than 3 million people worldwide consistently. Despite the progress in the treatment of manifestations and prevention of acute exacerbation, few advances have been made to improve disease, movement, or influence mortality. A better understanding or comprehension of the complex disease components bring about COPD is needed. COPD is a lung disease that causes obstructed airflow from the lungs. Symptoms include difficulty in breathing, cough, sputum production, and wheezing. It's caused by long term exposure to irritating gases or particulate matter, most likely from cigarette smoking. Smoking cessation programs, expanding actual and physical movement, and early discovery of comorbidities are further key segments to diminish weight of the illness. In any case, COPD can easily be treated and prevented, but without a worldwide political and economic efforts to lessen the tobacco use, to control and regulate environmental exposure, and to discover options in contrast to the huge utilization of biomass fuel, COPD will remain a major healthcare issue for quite a long time. For nursing education recommendation, as the researchers will prescribe that research studies like this, one, be kept on improving and guarantee the aptitudes of students, nurses, as they come their way of becoming professional medical services provider later on. Case studies permit students to meet the advancing medical services demand and build up the role of making innovative solutions for medical care conveyance and prepare them for variety of settings. Case study and research sparkles interest and curiosity, which refines students' knowledge and grant them to acquire new abilities. For example, making rapport and gathering important information. These aptitudes would permit them to create and deliver a successful nursing care to their clients later on. We accept that learning is a deep rooted measure, and in this manner, ought not to be restricted, yet all things being equal and boundless. For our nursing practice recommendation, we recommend to keep creating contextual investigations altogether for medical care providers to convey quality and proficient medical services benefits that elevates holistic well-being to the people. This is to guarantee that aspiring nurses are well equipped with information, abilities, and experience that they may deliver vital medical services administration to their clients. For the nursing research recommendation, building up this research book or this case presentation book has caused us to understand that the art and study of nursing is boundless and better approaches for care unfolds practically every day. We were taught that there is a variety of cases in various clinical settings, hence, it is significant that we stay educated with the new directions in nursing with a goal for us to give better medical services, giving mentally methodology, strategies, and aptitudes to our future clients. Our review of related literature, we have here the self-management practices of smokers with asthma and or chronic obstructive pulmonary disease, a cross-sectional survey by Claire Hayes Watson, Henry Noss, and Sarah Moody Thomas. Now, I will just give you a summary about this literature that we've got. Now, this was the first study to examine the relationship between adherence and smoking in patients with asthma and or COPD, and this study examined adherence in smokers across multiple measures of self-care in addition to medication taken. Now, the purpose of this study was to characterize the relationship between smoking status and adherence to multiple measures of self-care including medication taking, medication filling, appointment keeping, yearly vaccination, carrying medical supplies, and healthcare utilization in patients with asthma and or COPD. Now, the results of this or of their study may also inform the direction of new clinical research focused on smokers with chronic disease. Now, their study provides support for the inclusion of smokers in trials as considerations for poor adherence should be examined for all patient groups, being that smokers make up a substantial proportion of asthma and COPD patients. Their needs should also be considered in the development of new therapies. For the second review of related literature, it is the pulmonary rehabilitation and cardiovascular risk in COPD, a systemic review by Youssef S. Aldabayan, Ahmed M. Al-Rajeh, and John R. Hurst. Now, pulmonary rehabilitation or PR is an effective intervention in COPD. However, the value of PR in reducing cardiovascular risk in COPD is unclear and there is no existing systematic review. Based on their literature, COPD is defined as a common preventable and treatable disease that is characterized by persistent respiratory symptoms and airflow limitation that is due to airway and or alveolar abnormalities usually caused by significant exposure to noxious particles or gases. Now, arterial stiffness is a gold standard predictor of individual cardiovascular risk. and is a biomarker of elevated cardiovascular risk in COPD patients as it is in healthy populations. It can be measured using aortic pulse wave velocity, and it is also known that COPD patients have increased arterial stiffness compared to controls, and we have previously reported a relationship between the frequency and exacerbation and arterial stiffness. Now, they have systematically searched for and reported those studies that evaluated the effect of PR on CV or um, and outcomes in COPD. Now, there is some existing data evaluating the effort of PR on cardiovascular risk in COPD with one larger and higher quality negative study and two smaller positive ones. Now, this study heterogeneity results in continuing controversy in the field. The negative study also report interpatient heterogeneity and responses that are unexplained, require further evaluation, and may be clinically important. Results generated from this report will be of importance for researchers interested in assessing the benefits of PR or pulmonary rehabilitation and reducing cardiovascular risk in COPD. And this is our references.